how important it is to make wills and do living will. And I can testify for myself in my own family. When my parents, my mother was dying of cancer, and they had, I lived in Kyle, which is 50 miles northeast of Pine Ridge, and they had wanted to talk to me. And there's 4 brothers and 4 of us women in my family. And I didn't know what the meeting was going to be about, or if there is a meeting. But when I got to my mother's house, she was lying in bed and she heard my father both. I have a brother in White River nursing home. And I go over there periodically or have contact with somebody through phone, And at that time, when my father had said that they wanted me to take over the responsibility of taking care of him after they pass on. And that was kind of the gist of the meeting. Of course, I didn't think that it was that important. I thought, yes, I will do what you want me to, was my answer. And not knowing that their lives were shortened. In August of that year, my mother passed away. And then in December of the same year, my father passed away. So they knew that their time was coming, that it was shortened, and they wanted, my other brothers were not available at that time, and neither was my sister. I had 2 older sisters that had previously passed away, so I was the only one. And I was sober. So, as speaking from the words of an elder, through my own experiences, I was able to share with the elders in Lakota, in my language. And Valeria and I went to various districts, but prior to that, in our meetings with Mary and the other elders, we collaborated with legal services, and they had given us their approval and consent to partner with us, as with the other health agencies on the reservation. So to make a long story short, Valeria and I were the only ones left of all the elders that had come to our meetings. And it touches. It's very near and dear to me what I can do for my people, or our people. Not only just us, but whoever is interested to invite us. And I appreciate your invitation to be here. And I thank you. But we also had an artist that we, through the funding, that we were able to do his artwork on the Gallatin. So there was a lot of work to this. We met many times over that initial portion of getting together, and you can see in the back there were all our partners. We're working with Pine Ridge, twice, and they invited us up to the radio, our radio station, and we talked several times over the radio. And like I mentioned, we covered all the districts, 9 of them. And next week I'll be going up to Rapid City to cover the Indian population there. If I may turn this back over to maybe Mary or Valeria, maybe they can add to something that I have missed. Or if you have questions or concerns, whatever, you can let us know. And again, I thank you all for your invitation.
I'm Valeria Apple, and I found this program really interesting after I heard about it, and from Pat, and I wanted to be a part of it, so that's how I got to working with it. But I worked at the courthouse for 22 years, and my last 12 was as a court administrator, and I just retired, 8 years ago, so I'm doing a lot of volunteer work, and this is some of it here. That'll be at every meeting that we have, and we came up with this pamphlet. But the thing that really surprised me was when you talk to the elders about this program, they say, "No, I already did my last will and testament." This isn't a last will and testament. It's when you're sick and you can't speak for yourself, what you want, and have that elders. That was really something that they were surprised at knowing that they could do that. But I said, "It's here." I said, "You give them pamphlets." But it was fun going around talking to all the elders, and they're interested in it too. And they want us to come back. They have questions, and they call us and stuff. Where do you do that? You can go to any what do you call that? Yeah, US Works. Legal aid. You can go to legal aid and get this done too. So maybe they were going to try some of that, but I think we just explained everything here. Just reiterate. Thank you.
We can also entertain questions, but I think that, we kind of gave you jumps and starts as to how this progressed. So essentially what brought me out to the reservation was I met with a palliative care physician, and that's a person that's trained specifically to provide palliative care. She was board certified. And I was working with undergraduate students at the time when I taught at Augustana. And her question to us was, why do I see so many individuals from the Native American population coming to the eastern side of the state to receive care in palliative care? Why is that? And it stopped us all short. I didn't have an answer. I didn't know either. And as I said, most of my work prior to that had been within the schools in Pine Ridge. Hadn't really tapped into, I knew many elders, but had not really spoken with them about that. And so over a period of about 3 months, we met with palliative care providers, and we also met with Native American healthcare providers. And Ruth was one of those individuals who graciously allowed us to interview her regarding her perspectives. And what we found in that early work was really the hesitation about even offering or thinking about offering palliative care out on the reservations was our own. And it's because of us, many times, as white healthcare providers, feeling like individuals would not be receptive of it. And what we learned is, especially after talking to our Native American healthcare providers and also Ruth, who works with many, works within IHS, is that the elders want this type of care. And so we had to get over our own concerns and barriers and to realize, okay, so what's the next step? So that's where I wrote for the grant to come out and meet with these elders. And as Patricia mentioned, there were probably, I would say, 4 or 5 consistent elders that would come to those monthly meetings. And that first meeting really was about what is palliative care. is this culturally acceptable? What, you know, can we speak about when your time is coming? Is that appropriate? Because in the literature, it says that some Native American tribes you don't talk about dying. So how do we approach that? And I think I will allow either Valeria or Patricia to talk about how they broach that subject. Would you guys like to share that now? Okay?
Yeah, as Lakota people, you know, on our reservations, you know, we're Lakota means Walakota. You know, that's us indicating that we live in our language. Our language defines us. And how we live, how we approach to things, how we deal with things. In a long time ago, in the spiritual sense, we are who we are because we believe a certain way, you know. And regardless of what the belief is in today's age, we still have that underlying respect, basic respect for each other, as well as for our elders. And, you know, in our trips to various districts and Valeria we can attest to the fact that there are many elders who are not getting the care that they need. They are sometimes being abused, if not verbally, then sometimes physically, and of course financially. You know, that's the only time, first of the month syndrome, we call it. You know, that's the only time that elder, or the one who is getting the money, that first of the month is important. It's the only time there. And those are the negative side effects of our culture today because of alcoholism and drugs. Our value system has deteriorated to such a degree that, you know, that basic respect has gone out the window with our young people. And it's not just here, I think it's universal. Myself, you know, from what I see on Facebook, or, you know, on the internet, on the media. And so, you know, how do we struggle to get back to the way it was, the way it should be, in taking care of our elders? And we had had many discussions. And we, as individuals and elders in that core group, knew of instances where families were, and I'm sure that you probably in your communities know some type of abuse or neglect. And I know we can't be a savior to everybody, but you know, at least with the palliative care, my hope and our hope is that we reach some people, some elders out there, that there is help. You know, there is help somewhere. And that we need to, you know, be approachable. When we're discussing, if we're dealing with, in my case, if I'm dealing with a brother or a sister, you know, I would respect what her wish would be, what would you like? You know what? And as in my case too, you know, I only have one daughter, but I have various grandchildren and great-grandchildren. And I would like it when my time comes. I don't want to be hooked on that machine, you know, to keep me alive. You know, some of them, even today, even some people who have kidney failure would rather die than be on the machines. And so it happens. I know several people who have done that, who have chose that. And the family respects it. You know, so I guess, you know, in saying that, when we approach the individual in a hospital setting, and we explain to them that in case of they have strokes or heart attacks, you know, what would happen, you know. And I'm pretty up on my own health care. I don't want anybody to be, I don't want to be dependent on anybody, you know, if it's causing their lifestyle to change. That's just me. I'm independent and I'm self-sufficient. I can handle my own. You know, I did my will several years ago. It's been amended. I still have to do the durable care. You know, then I'm kind of slow in that department. But we explain to the elders, you know, in our language, how best we could, how they would like their decisions to be respected. And maybe, you know, that might deter some of them, some of their children or their grandchildren, being in court, or that's only secondary to what the elder wants. No, I would like my wishes to be respected. You know, when my time comes, when I am unable and in the hospital, I would like, you know, certain things to be done and to be carried out, you know. Give me that respect. Give me that dignity that every human life deserves. So, you know, it's hard when approaching a sensitive matter. And that family might have a Catholic background, they might have Protestant, they might be Native American background, not Native American, what they call it. Anyway, traditional, they would like to have their traditional ceremonies, or somebody to, how would they, you know, in case in my death, what would my last rites be? You know, and I can say this, but there are a lot of elders out there, excuse me, out there that are suspicious. And maybe they're not approachable. Maybe they don't want to hear these things. You know, so I think it behooves us as workers in the field how to measure that sensitivity. you know, that respect that you're gonna give to that person. And so it is a sensitive, you know, matter. I think that's the first on the agenda, that, you know, when you're approaching somebody, maybe your own relative or parent or somebody. Yes? I'm sorry.
Did you feel like you had success
I have success.
doing?
She was really upset. She said her mother was dying, but she didn't want to die in the hospital. And so we went, and one of the Lakota speakers spoke to her, and she said she couldn't die there because the windows were closed and her spirit couldn't leave. So we went and talked to the hospital administrators then, and they took her to a place where it could be open to the outside. And when they took her, she was happy, and she breathed her last in that, and she looked like she was happy. And I can think of another time where legal aid was brought into it. I went to visit I had an in-law relative who was really upset. She was a pretty young woman. She was dying of cancer. And I went to visit her and took her stuff, but she said, "Lois, I don't want to die." She said, "My sons and daughter are really fighting over who's going to get what," she said. So I said, "Isabel, you know what you can do?" I said, "While I'm here, we can call legal aid, and you can make a will and say," I said, "do you know who you want your things to go to?" She had a lot of land, and one was a home place where she lived. So we called legal aid, and you know that they came, and she died a lot easier because the will was made and the kids didn't fight and she passed away. So we do have a need for it. Maybe those are really widely separated cases, but my own belief is that we're given a gift of spirit from our Creator, and how others treat that spirit we have is really important, and especially when we come to the close of giving our spirit back to the Creator. That really should be a respectful thing. And I hate to think of anybody dying alone. I have a brother who lives alone and is ill, and I worry about him, and I worry about others that might have that same situation. And I know we've had people who did die alone. They froze to death in trailer houses. And to me, that's unacceptable. But how do you get the people to change their minds? How can you be successful in reaching these people? It's really hard when they have a mindset that doesn't see any benefits for what they're doing right when it's happening. It's hard to make them realize the benefit that will come from their action. Thank you.
I don't think there is a success per se. I know a lot of our elders in going to the districts, as I mentioned before, have made their wills. And to follow that up, you know, that's not our position. I think that's the legal aid's position between you know, when I say sensitivity to the issue and making that will known, and we encourage them, you know, but realistically, you know, when you look at the facts today, you know, and you call a meeting, you know, who is going to be willing to be there, or sad to say, if they might be drinking or using drugs, You know, those issues are all out there realistically. So I can't say that there is any success. Each individual, each family member has to answer that. Maybe you can answer that.
Your question is well placed, and I also, the two stories that you shared are very common, and ones that I believe that we heard within even our own when we conducted the focus groups. And that it's also occurring not only within our reservations, but it's also everywhere. And I think for us, number one, it's too early to measure whether we're successful or not. But what needs to happen is we need to start to have the conversations. Because we're not going to see anything change overnight. As you know, it will take time. But I think but we have to be more deliberate and less hesitant to raise the questions. And so, for example, for me as a nurse educator, I teach with South Dakota State University in their College of Nursing program. What we are doing within our own program is implementing what are called the ELNAC, which is End of Life Nursing Education Consortium. It's an educational program where it trains, where all nurses truly and all healthcare providers should be trained in what's called primary palliative care. And that is when I walk out the door, any of my students, once they graduate, they should be able to sit down with anybody, no matter what their ethnicity, their cultural background, color, anything, religion, and recognize that somebody's chronic illness is maybe on a trajectory that looks like we're not getting any better. We seem to be coming into the hospital more often, but yet a decision hasn't been made about what do you want to do? And for many of us, that's the hardest thing to ask because we don't know how and we don't want to offend. And for me, working with Valeria and with Patricia and with all of the elders, it was eye-opening for me because I learned that my own hesitancy as a white person was getting in the way. And that I needed to bring who I was, my genuineness, my knowledge, my skill, and my concern, and demonstrating respect in every step of the way that I would be fine. And that's what we need to work with individuals, to be able to say, you know, Harold, I've been seeing you for a few days. I mean, I've seen you now come into the hospital. This is like the third time in the last 3 months. How do you think you're doing? How do you feel that you're doing? And really that reaching out and asking them, where do they feel they're doing? And having them have that opportunity to voice what it is. And oftentimes they know. They know they're not getting better. And so then and I always remember Valeria raising this question saying, I tell them, what are you gonna do when you can't make that decision? What do you want to do? And having them voice the question. And so I think that's what all of us have to learn, especially in the healthcare field, to be able to ask that question and to take the time to listen and to be ready to hear the answers. Does anybody want to add, Valeria or Patricia?
Yeah, I just forgot to mention that when my parents called for a meeting that time, before they passed away, it was to take guardianship of my brother. That was their intent, to give me that, pass on that responsibility to me. So I did that. I petitioned the court and granted it. Went through the whole guardian process, so I'm still his guardian, his legal guardian. So, you know, when it comes to my time, and we each all as individuals, I know that we put in here that circle, the circle that in what we believe as the circle of life. You know, we're at that last quadrant where the eldership. You know, we have passed on through this whole cycle, and now we're at our last quadrant, and it's a natural thing to die. You know, what I believe about life is part of dying. When we first are born, it's a process towards that end of life. So I don't like to impose my will onto others, because I believe in God wills, you know, that there is a higher power besides me, and I'm not him. And that God, you know, gave us a free will. So I pass that on to every individual. And I think that might be the primary forethought in my mind when I approach somebody that's end of life, you know, and I believe the Spirit will guide. You know, the Spirit does guide, and you know, because of our beliefs, you know, no matter what, life is precious. Life deserves, at the end of life, respect and dignity that every human being has that right. So, with that, unless there are any other questions.
Valeria, did you want to say anything or add regarding the conversations or how to approach, or things that you learned as you were having the conversations in the districts? And also you shared, because you were delivering meals in the Manderson area, and you actually brought the pamphlets to the homes and talked. Do you want to share a little bit about that?
Okay, on volunteer basis, I serve 22 to 30 meals for the elderly in Wounded Knee, because they have nothing there. So I took it upon myself to just go deliver noon meals. And I talked to them a bit on this pamphlet, and I showed it to them. But that's where a lot of them said that, you know, they had the last will and testament, but this is different. And I had to explain it to them. And they said they wanted something to do with that, but then they had big families, you know. That's just one thing I brought up. They had big families that, you know, where all the grandchildren are home, and they all fight over his meal or their meals when I get it in there. But I told them that these are things that you're going to have to go over with your grandparents, you know, and because I said, what if they're in the hospital, and if they don't want that resuscitation thing on them, and how they're going to do it, you know, they'll tell you. But the other grandchildren will say this and that. It's got to be his decision, you know. And I explained things like that to them, and they said they were going to get back to me. But since then, I quit serving the meals. I think about 2 or 3 months now. So I haven't heard, but it's going to start up again. So I'll be going around with that. But they all have the pamphlets, and they're really interested in all that. So.
I had mentioned the training, the End of Life Nursing Education Consortium, that is a specialized training. I'm called a Train the Trainer. So, and there are 3 of us at SDSU that are capable of doing that. I had a conversation. We've met with the social worker at the Pine Ridge Service Unit, as well as the social workers at the dialysis centers on Pine Ridge. And overwhelming response just to this pamphlet saying, why didn't we think of this? Because of it's in simple terms, and it kind of spells it out. Currently, the Pine Ridge Service Unit has no way of tracking how many advanced directive completion records that they actually have, or if they do have a tracking mechanism, they currently don't track it. So we aren't able to see, how many were actually initiated. The other thing that I spoke to the director of nursing, the assistant director of nursing, regarding training staff to care for individuals that maybe come into the hospital in caring for somebody that could be at the end of life, or maybe is just starting to be, their chronic illness is getting worse, so in better control of symptoms, and asking for better medications, or checking for emotional, spiritual, or even social concerns that might be going on. The interest in Pine Ridge is very high. The challenge is that it's competing with the other crises that are occurring. As we know, the suicide crisis is an issue. So it's how do you raise it to the forefront that this is something. That is something that, again, Rosebud could think about. Are there individuals that are trained in end of life that would be willing to come out? It's an 8-hour session. And with that, it gives you a basic skill set and knowing what to do. And there's always further education that you can do. I'm also certified as a hospice and palliative care nurse, so have undergone that extra training in order to be able to offer a higher level of service. But that is one area of getting staff trained. Nurse aides may also attend this training because the key component, if you noticed in response to the question, is communication. That is essential. And learning to listen. Yes, understanding how to do dosage calculations, but if you think about the CHRs and your nurse aides, they're the ones that are right there with those individuals, having that conversation and being able to be open and to listen to that. What we learned as we went through the domains about palliative care there were many that were just kind of a big, I guess, a flashbulb moment for me, was thinking about the lack of interpretation services. I'm not sure what it's like here on the Rosebud Service Unit, but say that an elder who their traditional language, as it is for Patricia, Lakota is her first language. And I need to deliver some not some great news to her, some bad news. And I'm not going to do that. But if I had to, the preference often for an individual where Lakota is their traditional language is they'd rather hear it in their traditional language. And I had never thought about that because so many are bilingual. She speaks perfect English. Why would I even think about that? And it translates also over to other nationalities that we care for. And so that's something for you guys to think about. Do you offer translation services? So Ruth is shaking her head yes, and in Pine Ridge that isn't accessible. But do we ask is the other. I'm sure Ruth does, so most of the time. So knowing those kind of things. The other is individuals coming in to our service units. How are they trained about the culture? Do they receive any cultural sensitivity, cultural awareness training? And if they do, who provides it? I know when I used to bring nursing students into Pine Ridge, it was like a 1 little hour snippet. And believe me, the training that they received had come from me, from the years of experience that I had working out on Pine Ridge. And then we would talk every night after they came home so that way they learned to deliver care in a culturally appropriate manner. So these were things that we knew have to happen, and they need to happen not only with palliative care, but just within the facilities themselves, that they need to change. The other is, we had talked about a home health program has been on the back burner in Pine Ridge for a number of years now. When we started our conversations about palliative care in 2014, our last thing that we had heard is that the paperwork had been submitted to the state, and that's as far as it has ever gotten that we're aware of. For us, a tribally owned home health program would be ideal. And I think that's something that you guys are also talking about. Because if you have home health, then palliative care can be a part of that, and then hospice can be a part of that as well. And within your care center, you can also offer palliative care and end-of-life care services. We had also brainstormed telehealth or telemedicine, because the challenge that occurs with offering palliative care is a lack of palliative care providers. There is greater need than we have service providers. Now, we can train individuals to be like a generalist in palliative care, which is, if we provide that end-of-life nursing education, that's a good first start. But when we understand that maybe those symptoms are getting a lot higher than we need, and they're seeing that their general provider who isn't trained, how do we know that we need to get more medications? Who do we need to talk to? Well, that's where you could tap into a palliative care specialist to get that. But how would we do that when there is palliative care in Rapid City at Regional, but it's very limited? So that is a question, et cetera, for us. And again, as we mentioned, we knew we needed to start somewhere. Palliative care, our dream is that we would get palliative care on the reservation, and then also hospice care on the reservation. But we thought what was urgent was to start having the conversations about what are you going to do when who's going to make your decisions when you no longer can. And we felt that was something that we could do right now. And our elders, and that's where the decision was made to have it elder-driven, where they led the conversation. So I think the biggest part or takeaway is, you see me sitting here. I was asked to be here because, as Patricia will lovingly say, I'm the one that started this or got them into this. But I was essentially their support system. They were the drivers. They were the ones that initiated. They were the ones that, the pamphlet that you see is their creation. I was the one at the keyboard, and then took it to the South Dakota State University graphics department to have it all put together. So I helped facilitate, but I took a very back seat. And I think that's why this program has been as successful as it has been, if we measure our success in small steps. So just knowing that you don't have to have a grandiose plan, but how do you start small? And how do we start to plant those seeds where they need to start? So I will be quiet. Does anybody have any questions for us, or do we need to take a break, or? Sure. Mm-hmm.
Yeah, just to add to what Mary was saying a while ago, that all the places that we have gone, the dialysis centers, you know, I have yet to make it up to Rapid City, but the healthcare center in Kyle, I was just over there last week, and they invited me back. They want all their staff members there at the Kyle Clinic to know about palliative care, you know, and I talked to their administration. So I'm going back over there on May 6th to, I guess, help train the health educators, or help the staff there, to put my input into it. I just wanted to add, wherever we went, we were well received, and they always invite us back. Okay, we can have a break.
Okay. 10-minute break.
There's coffee and water and some snacks up here. You guys are welcome to help yourself. Is that off?
We have, you know, I believe that, you know, God happens. You know, we don't have experiences by accident. I think everything happens for a purpose. And I mentioned a little bit about Valeria, that she was the court administration for a long time. And I had the privilege of working with her and under her supervision. And what I learned from that experience is, like I mentioned before, we see a lot of, at least myself, I see a lot of families that upon the death of a loved one, they're already in court fighting over the body. And that is so disrespectful to that person. And, you know, my personal hope is that that doesn't happen, you know, but we're not a prevention program here. We're information. And what, as you all know, that education is the biggest and greatest tool that we can give to one another and to our elders. That education is what that care provider must give to that person, you know. Yes, there is superstitious out there, but that's what I'm a realist. I deal with real issues. And in my line of work, I've, you know, truth is always the best tool also, you know, that that's what we give. And truth is always, we can dispel a lot of those superstitions, but we can't change what they believe. What they believe, you know, that's their choice. And we as individuals need to respect that. So I guess in closing, I guess I just want to say that this Wakunki means elders, you know, and Iwashte Bikte means care for the elders. And that's what we came up with to emphasize that, you know, the care for the elders. You know, it's a fact. We all get there in one way or another, you know, but it's a cycle of life that neither one of us can avoid. And so being a realist, you know, when I'm asked about, you know, I'm not a problem solver, you know, nor do I think I can save anybody. That's not my role. My role is to just care for that elder, enough that you give them as much information as you can. And so, you know, as I mentioned, most of all the places we've been to, we were received, you know, well received. They invited us back. A lot of the elders that, you know, during our trips to certain districts, you know, have made their wills already. But the next step is to their health care. And I did say in one of our focus groups that, You know, why isn't something like this taught in our nursing department at OLC? You know, that's a question that I still would like, you know, would like a reply to, because it should be, you know, because healthcare is healthcare, and they should be given all the information as nurse, you know, providers, that at least they have that piece of information in their tool of work, you know. So anyway, I just wanted to add that. I don't know if St. Iglesias has that, you know, in their nursing department, or, you know, that's something that we, you know, I would encourage our OLC to have, but I'm not sure if OLC does.
Is this on? I know for St. Iglesias University, the nursing department, they have the CNA, and the instructor said there is a piece in their curriculum that covers, I know they do the end-of-life care. So I don't know, I was listening earlier, you said that you're an instructor too for Mary for the end-of-life care. And you said it was 8 hours? Is that something that is, do you get like receive a certificate, or is it, does it require like being enrolled in a university or college and for credit, or can it just be a certificate?
It would just be really a certificate of completion, right, that you had taken the course.
Okay, would you be recognized by the state for something like that as well, or?
Meaning like for contact unit hours?
Well, just say down the road if there was to be a home health program and you want to get people certified in different areas, would that be something to say, you know, if somebody had gone through that they're certified to provide those services?
It's not necessarily a certification, but it would be evidence that they had taken the course. So I think that would be, if it was of an interest for individuals to do, what we could do is make sure that we get it approved for contact hours for whatever that would be, so that it shows on their training that they have had X number of hours in this type of specialized training.
Because I'm just thinking, we have a lot of CNA students. We also have the CHR program. They come through the university to get their CNA. So there would already be a number of people that could receive that additional training to help.
And I don't think they would probably need that entire 8 hours, because some of it is actually on, you know, medication management, et cetera. So I'm sure there's certain pieces that you could pull out, but especially the communication components, caring for individuals, the communication skills, end of life, care, et cetera. But for nursing specifically, as I mentioned, there's a mandate from the American Association of Colleges of Nursing, and also from the Hospice and Palliative Nurses Association, along with the American Nurses Association, to integrate what is called the CARES program, which is all about palliative care. And it's essentially making sure that you're integrating within those fundamental areas, or those 2 years that you have them in their basic nursing program, that they are trained in this when they walk out the door. And they're trying to get it so that it starts to happen in every single nursing program. And for sure, they are targeting baccalaureate programs. So, but does that mean that it can't translate into the associate degree programs as well? Yes, it can. So you don't have to be in a baccalaureate program. It can be taught.
I just have another question too. When you were talking about the cultural sensitivity training for health providers coming onto the reservation, did Pine Ridge develop some type of a training?
From what I hear, when a doctor or somebody is transferred into Pine Ridge Hospital, they do have a cultural, I don't know how long or who teaches it, but they do have some type of cultural sensitivity workshop or something to that effect, from what I hear. But I can say, having said that I just hear through rumor, so I can't really, and I know my own personal primary doctor, a lot of people in our area know my dad, my father, and when they see my name, they, any relation to, and they start the conversation that way. But as far as, I think, in observation, a lot of the PAs are the doctors. They do have like their stethoscope, and they have those beaded. So I'm sure there has been some contact, but again, like I said, I'm not for sure on that.
I know that one of the health educators, Dakota Highhawk, who works, I'm not sure if he's still affiliated with Tribal Health Administration. When he was one of the members of the focus groups, we met with elders, plus we also had a representative from Health Administration there, and that was Dakota's role. And he was pretty adamant that it's been kind of hit and miss with the service unit in Pine Ridge. Whether that has improved since our focus groups, I don't know. But for the cultural sensitivity training, because he has been invited to speak there. And he is probably, 25, 30 years old, and he's a fluent speaker and, has had a very traditional upraising. So he's an excellent representative, but he felt that it really needed to be better. And I think, another twist to that, as we communicated and talked, was when you think about the United States and how we have the Peace Corps, and the Peace Corps sends individuals to other lands, countries, to help deliver care or whatever it is they're doing. And they have immersion, they have a cultural training, they have language classes. And our reservations are sovereign nations. But is the requirement when somebody comes to work in our service units, do they have the same requirements? And why don't they? And that's just an awareness. A question that, this is kind of a different offbeat, is we had a great conversation occurring during the break regarding individuals that have these chronic illnesses, whether it be heart disease or chronic lung disease, and the honesty that is lacking sometimes when they are in the healthcare facilities. And I have just finished a research project where I had the honor, actually, of interviewing hospice nurses from the Aberdeen area and from the Sioux Falls area. And what we were trying to understand is, what is it about their communication that is different? And we haven't had a chance to analyze all of the narrative data that we received from them, but what was resounding was the key thing within their communication is that they are always honest. If you ask me, I will be honest with you. And sometimes I have to start, again, that conversation. It has to be gentle, but you're going to know the truth about where you are in your care so that you can start planning for what the next steps are. And you will find that for some caregivers, and I know Ruth will testify to this, it's not easy to be honest. It's probably a very challenging thing to be honest. But families appreciate the honesty because then they can start to plan and to make, ideas. So those are some thoughts as we gather together later on. How do we generate those conversations? So we're having some good discussions about if we were to get started on a home health or a hospice program, what would that look like? what programs have to be involved, what areas, where do we get the funding to even begin that? Where would it be housed? Would it be through IHS? Would it be through the tribe? So I think after we break for lunch, this is something that I think, or after we're done with lunch, that I think all of us would really hear, because as Patricia and Valeria and I were talking, what we hear from you guys, we can also then take back, because the tribes are very, the resources are very similar on both reservations, so we can learn together. So, does anybody have questions?
I know I need to add too that in going to the districts, we did go to a few healthcare fairs, and there we distributed. And now I can say Valeria and I, they had a health fair in Pine Ridge at the hospital, and also one in Kyle just a few weeks ago. And we were well received, because, excuse me, because they haven't, this is new to them. The healthcare providers there, this was new to them. So we were well received in every place we went. And the doctors and the nurses and the various departments in the clinic or the hospital, we were well received and, encouraged us to go back.
And I think the other key piece about the brochure is it's not copyrighted. And how that actually started is we had one that was from the South Dakota Comprehensive Cancer Control Program. It's on their website, very generic. And I brought that when we had our next step, when we were talking about this advanced directive education, and Valeria and her brother Garfield and Patricia and I all met over, I think, 2 different afternoon sessions, and took that brochure and then translated it in, because we had permission from South Dakota Cancer to change it to fit our needs. And we're willing to share with you that program or that database, so that you, if Rosebud chooses to do one that is specific for them, they are welcome to do whatever they want to with that. Regarding Dakota Legal, and we were told by them, and I'm not sure who provides your guys' legal aid services, that anybody over the age of, was it 62 or 65? Was it 62? Do you remember? Patricia, do you remember what he said? Over the age of 62, that those services are free. And he also told us that if they had more than, it was over at least 3 people, that he would go to the districts. Now that's been our other challenge, is getting that go-to versus having to travel either to Martin or to Pine Ridge, because as you guys know, that is a challenge. And they also do, not only do they draft the last will and testament, they also will draft living wills there as well. So you might want to check with your legal services to see what services are offered.
From what I know about legal services in Pine Ridge, I believe their parent office is here. Yeah. I'm pretty sure that's the way it panned out. I think there was Miss Valandra was our chief judge several years ago, and she kind of, when she left our courthouse, she got into legal services. And that's how I made my first will, is through her and the information that she provided, to our community at that time. And that's been several years ago, at least 10 years ago, I think. And so I know the legal services down there in Pine Ridge is hooked up. In fact, our wills that are written down there, they're archived up here. That I know. So the BIA used to give free, drafting up the wills at one time, but they don't do that anymore. So it's just legal aid services down there. And I think they're only there 4 days of the week, I believe. So, I don't know if it's our position to follow up on our referrals to them, but there's a lot of need. There is a lot of need at that, especially with the buyback and social security and VA benefits, all those should be in that will. As important as the health care, especially the ones on dialysis and cancer. I myself am a cancer survivor. I've been cancer-free for 9 years now, so. Anyway, I know how important it is to make a will. Okay.
I was just going to say, I was asking somebody one time about how many people, especially our elders, or just anyone in general, go out and try to do a living will or the will, and I was told that because of that superstition, they think if I do this, something's going to happen. And so you can kind of think too, like, again, that conversation is so important because that's where they start thinking about it, at least getting the information, and then when they're ready, they can do that. Because just like when your baby is, you hear a baby's coming, the mom, the prenatal, she doesn't go out right now 6 weeks into the pregnancy and buy all the things for the baby because of, again, that superstition. But sometimes it is good when when you have somebody that can share what they want. And so it takes that, not that it's a burden, but like if you have a relative that that the end of life is getting close, that if you know the wishes of that relative, then you're still taking care of them even when that time comes. So not just their health to where they make that transition, but also taking care of their body when that time comes. And it takes the guesswork out of, well, I wonder if we should do it this way, or who's going to be in charge, and who. So it helps the family to keep peace, I think, in the family, because then you're still carrying out the wishes in a good way of what your relative wanted. So I just see it as a good way to help to keep the peace. And I think too that when you hear relatives that say they have they have a relative that's, it's getting close to that time, the end of life time, and they're there caring for the relatives. And it's sad that sometimes they feel like they're the only ones caring for the relative. But I always think too, just from hearing what they share, is that for them being closest to the relative in that time of their life, that it also helps to begin the process of grieving and the acceptance of what they know is coming. And again, I was sharing earlier with Patricia that I think being close to an elder, especially during that time, it's a kind of like a place of honor, because that's where the storytelling, the oral history, and just really having that quality time. And when the relative passes, especially if it's an elder, I think the person who's caring for them is not that they grieve any less, but they've been prepared and they've shared that quality time. They've done everything they could for their relative. And for those, I think, that don't have that connection in that way, they suffer the hardest and they grieve the most. And maybe they're the ones that, like you say, you see sometimes the material things become more of a struggle that way. But I just think too, when you're more connected and part of that process too, it helps in that grieving. And and maybe that's if they share, maybe maybe it's not in writing like a living will or like that, but they're sharing with that individual, this is what I want, and they can write it down or put it somewhere so it's there when they need it. But I'm talking, I'm live streaming. I'm scared. Put it back. Okay. Do we have anything more before? I know the ladies got the lunch already. We're ready for our meal now. If anybody have anything to add before we take that break? And just for the people that they're live streaming, this will be while we're eating. It's going to be turned off. So, okay.
Yeah, so there's soup and fresh green salad and fresh fruit. So the soup I think she'll have dished up at the window.
to talk, give a perspective from. And I think Ruth also has some really good ideas, and I know Ruth needs to leave for sure by 2. So. To talk about, I think you had mentioned we have homemaker services. We know that there's not a home health nursing for skilled nursing program here on Rosebud, also does not exist yet on Pine Ridge.
No.
And we know that that would be a natural hub for hospice care, not palliative care, but hospice care.
Right.
So for that delivery mechanism. But with the Department of Social Services, what currently services do we have that are available to elders?
We can provide case management and complete in-home assessments, which determines what ability versus capacity, so we can figure out what an individual needs. And then when we get to the point where we've made that determination, the problem is they don't have access to services in many areas of these 2 counties, Todd and Millette in particular. So we're only able to do what we have providers available for. So we have caregiving services. The caregiver program for us is a bridge program, and what it's meant to do is it's meant to, when there's a new medical event that happens, then this program is meant to obtain equipment needed to manage someone in the home, and it's also meant to develop those relationships with a caregiver, care provider, that they could maintain in the home after this medical event. So by a bridge program, what I mean is, our measure is usually about six months to 18 months that we provide services under the caregiver program. There's no financial qualification, so you can have as much or as little and still qualify for this program. But we do home modification, we do chore services, we do respite care, all under this program, but the onus is on the individual. It serves the caregiver, and instead of the care receiver, which is different from our other programs, but also it's meant to give them help with whatever it is they need. So it's what we can do with this program is really wide, but it all depends on availability. So if the family, for example, was keeping someone at home and caring for them, and they couldn't find anybody to hire to come in and assist or to come in and do the contracting for home modification, widen doorways, et cetera, then there's nothing, the program's there and available, and there's just nothing they can do with it. So
But
that's one example.
It's not nursing at all, but it's somebody to come in maybe and help
Right.
with bathing?
Exactly,
Okay.
right, bathing, any kind of, and if they can find a nurse that can provide nursing services, then potentially the caregiver program could pay for that. But, it's only as good as the programs and services available in the community.
And you guys are housed where? Where's your office?
I'm in here, Lisa's office is here in Mission.
Oh, okay,
We have
okay.
a representative here in Mission. And we have some providers that come over from the Winter area that serve Millette County. So it's just their boundaries are where they end, is just where we're no longer able to provide those services.
Okay. The Circle of Life program?
Yes. Yes.
So could you have both programs going on in your home? Okay. So but what's missing, what's missing really kind of within that is the skilled nursing component, or at least that availability.
Correct, yeah.
But knowing that there's respite for somebody to come in to be paid for, so that caregiver, so if the caregiver works and that person that needs to be cared for shouldn't really be left alone, and if they can find somebody, are there qualifications for that person to provide respite care? Do they have to have certain qualifications or training?
Ordinarily, we discourage that if there isn't another family member or a neighbor. What we really require basically is daily contact with whoever the care provider is, or the caregiver. So, in other words, they can be providing cueing and supervision over the telephone if the person doesn't need anything more extensive than that.
Okay.
So it's really on a case-by-case basis.
So a very flexible program?
Yes, very,
Great. Okay.
yes. But limited, again, in the time frame. Because we think that the intent of the program is to adjust to that new medical event and then make a determination about whether they're going to remain at home or whether it's unrealistic to remain at home. And we think that that can happen inside that 2-year window.
Okay.
That adjustment should be made at that time.
One of the things that I see is that duplicating of services, that we see often down there in Pine Ridge. And we try to not do that because the elder care that we're looking at is a piece that should be independent, and that time should be given to the elder. That's what I think about it, because we had under the state social services, we had a program that did go into the homes and cooked for the elder, or did home health.
That would be the home.
Pay their bills, and kind of like a CHR, community health, but that program stopped, and it's now Circle of Life. And I know there's another one out of Pierre, I think, that periodically goes down there, but I'm not too sure about that one.
No, that's with the homemaker. The homemaker program does do the stuff, and Circle of Life is the provider that does it. And that's the same provider that covers the Rosebud Reservation as of November, October of last year. So they do food prep, they do light housekeeping, those kind of type of homemaker services. So there's 3 services: homemaker, personal cares, which would be bathing, helping with toileting, getting dressed, and then the next step up would be nursing, which we don't have, unfortunately. But we do have the homemaker and the personal care component here now on the reservation.
How many natives do you have on your program?
I just started I was just telling Tammy this, we started in November, October, and I'm up to 10, 11, I believe, right now, that we started. Marvine's been pumping those referrals out to me, so, yeah, we're quite a bit since then.
My brother was turned down because he was a veteran.
That's one thing, too. I mean, but we don't, it depends on, we can't, Tammy, you want to touch on that part in regards to the VA? Yeah.
Specifically in regard to the VA, again, it speaks to access. The VA will pay contracted providers to care for their veterans. They'll either pay the whole amount or a portion of the amount, but if there aren't any providers in the area, then you can't access that service. It's as simple as that.
And when you're saying
it's not exclusive to this area or to reservation areas. It's, there's an area up toward North Dakota and in Butte County, and there are a lot of big spaces. We're a very rural state and where access is difficult.
when you're saying providers, you're talking about certified nurses and aides, or what specifically about providers?
Providers are anywhere from providers of durable medical equipment, supplies, have nursing, CNAs, senior companions, you know, we deal with all different kinds of providers and all different certifications of providers, which is, we have Medicaid providers and non-Medicaid providers, and it varies from all different areas of the state, but they do have to be a provider for the state in order for them to provide services under our programs.
So they're hired by the state?
No, they're not. Think of it as subcontracted.
Okay. So they're under some separate program like the Circle of Life that,
Correct.
Yes.
okay.
That's separate. And what the Circle of Life is basically doing is taking those caregivers who we do not pay, because it's not, some states do pay caregivers. We're a state that's just not able to do that. So what they're doing is they are identifying that need in different areas of the state, and then they're taking that individual, making them an employee of theirs, and providing service to their family member, which is very unique. I've never seen it done that way before.
So how do family members, how do you know that somebody needs to have a referral? I mean, how do they just call DSS? I have this.
I get individuals calling me themselves that they think when they've heard that the services are offered, they'll call on their own behalf saying, I think I could use a homemaker. Marvine, which is out of the RST caregiver program, she's referred a lot of individuals. I get referrals from hospitals, clinics. Anybody who knows that the service is available can make a referral to me.
Anyone.
And so, yeah, so you don't need a physician's order or provider
all.
order?
No.
Okay.
And we do have basic services, I guess we can put that. That would be like the supplies and the equipment and nutritional supplements. That's a basic service. And then we have, it kind of goes in levels of care.
And then you had mentioned that, okay, so you're providing the homemaker services, the personal care services, and again, those are all different levels of certification. So we'd have to have a workforce, which it sounds like we do have CNAs that are trained that we could potentially use for that component. And then you said that magic other word that goes with it, the nursing piece. How do we get that?
Our agreement, I think.
I wish we knew.
Right,
Okay,
right.
all right.
I guess to the extent we could establish a formal partnership with the academic institution that would invest X number of spots to support our pipeline of sending our own away to get educated and trained and then come back and provide these professional services in our communities. So for example, if we were to go in a partnership with SCSU and you say, initially we're going to reserve 5 spots in our nursing program for a Sichangu referral person who wants to become a nurse, and maybe the tribe supports that financially, or we work something out financially in that manner, then we get the training, the individuals trained that are from this area, vested, have that compassion for the work that's being provided, and then that sustainability is there. So it's really establishing this pipeline of identifying where the needs are and then establishing the pipeline to meet those needs or the demands that we currently don't have. So SGU has the LPN program that's also a resource to us as a tribe that we need to utilize a little bit better than currently, but that we need all levels. So we need CNAs, we need LPNs, we need RNs, and higher. But my question earlier too is like, how do we establish, that's kind of where I was going with that, is we need to establish a way where we have a working relationship where this partner understands who we are, where we come from, and what our vision is for our healthcare, and help us get there and meet those goals that we have. And so kind of like that's really what I'm looking for in trying to establish the basic pipeline for healthcare with regard to nursing. There's a funding opportunity that has just been released. It closes on June 20th, and it's entitled American Indians into Nursing. And it's open to tribes, nonprofits. It's a federal funding opportunity that will support either upward mobility of nurses, so LPN to RN, or financially support whichever level they want to go if they don't already have a degree. So there's resources out there to support kind of this partnership, but I think identifying the partner or partners is kind of the initial step into
filling the void that needs that professional service that we don't have right now.
With the tribal buy-in was in our first beginning of our first focus groups, was we started with a resolution that went through our health education. And it went on into the tribal council, and that was approved. And so then because the tribe is sensitive to data collection from other entities outside and getting our numbers and then going with it off the reservation, we have a resolution, we have a board in itself that all entities that want to collect numbers of our Indian people, they have to go through this board. And that's what you did.
This project was actually, that's what delayed us from starting, was because I had to get Research Review Board credit because Valeria and Patricia were gathering numbers every time they went to the elder meals so that we could report back to our grantor, this is how many people they spoke to. We weren't collecting names, we were just getting numbers. But, they didn't meet in July, so we did not get approval till August, even though we were ready to go in May. But, so that's just one of the hurdles. But we need to get back to that conversation because there is an ability to do that partnership. So I think that's possible. Ruth, do you want to bring up some of your ideas? Okay.
First, okay. Before I get to my ideas, I thought of one thing. Evie, in particular.
Ruth, you might want to bring it much closer.
Am I close? I don't know how to talk in the microphone. Okay. Don't do it every day. I just yell real loud at my hard of hearing patients. Evie, do we have an elder care census right now for the tribe? Do we know how many elders we have and any statistics? That would be a question for me, right? For IHS or for Marvin?
The program that Pam has is she feeds the elders, and not every elder goes to the centers to eat. So she would have a figure of probably the ones that go there and that she services. And then the caregivers program is different from the elderly nutrition program. So on my part, I service about 278 elders, just our food box program alone. And there are many elders out there that are not on our program. Some come to get incontinence supplies and things like that. And there's just, we don't have a count of how many we have.
I do have some rough numbers at my office. I mean, I can forward those to you. I do the most recent enrollment numbers I received from the tribal enrollment office is living on our reservation. There's about 28,000 Rosebud Sioux tribal enrolled members living on the reservation.
Right.
And I do have a breakdown of age categories at my office, and I don't know the exact number of elders.
Yeah. See, what I was thinking, we all want home health nursing, and if we have an idea how many elders we might need to serve, then if we start an agency and we can start with 2 nurses or 3 nurses, and we're not talking about something really, really big, it might make it easier to get started, to identify some nurses in the community, because it's something we need. But I made a list, and also I wanted to say that and in IHS, I know we're a little in the doghouse right now, but I've had an elder clinic going for the last 15 years or more at Indian Health Service. And within the elder clinic, we provide a lot of extra services where, I kind of made a flow chart of all of the entities that I
interface with. So I help get services for elders through the tribe, through law enforcement, legal services. We have transportation. The tribal transportation can bill the elders' Medicare, Medicaid for transport services. Then we have the Rosebud Ambulance Service. With Marvine, we get durable medical equipment in addition to what we can get through the state, through LISA and the state services. We get nutrition supplements through IHS. We get them through DSS.
Ruth, can I ask you to hold the mic?
Oh, I'm sorry. I do not know how to talk.
Just hold it.
I'll just hold it. Okay, there we go. So there are a lot of different services we get. We have CHRs who traditionally go out and do home safety checks. The same with PHNs. We completely depend on the people that go out in the field and go to the homes and see the elders in their home. That's so much more important than what we see in the hospital when people come in. We don't learn that much about what their needs are. When they come to see us, we're dealing with, mostly their medical or social issues, but as a team, because we already are a working team, we just don't always identify ourselves as that. But to the elders, we are. We're a group of services that are available. And so I think the first thing that we could do out of this meeting is make a pamphlet of services available, and then also based on what we've talked about today, talk about durable power of attorney, advance directives, and living will, because I think we are kind of lacking that in the community. And if we educate everybody about that, it empowers the elders to protect themselves against people that would exploit them or manipulate them over, the legacy that they have built up over their lives. So I've just appreciated this meeting a lot. I have a whole list, but I'm not going to go over it right now. I have to get back and do clinic, and there's lots of other people. But, I think if we can increase adaptability for elders in their homes through tribal housing, through DSS services, add adaptive handicapped access, then you can keep people independent, you can increase their ease of mobility and keep them in the home longer. And that's so important to people. What I found from knowing most of the elders here is they don't want to be in an institution if they don't have to. They want to stay in their own home. And how do we increase that? The state program right now is increasing access to all kinds of programs to keep people out of nursing homes. For a lot of reasons, it's better for the elders. It's also cheaper for the state to keep people at home than to put them in a nursing home and pay for them. So I think that if we network with each other and build on each other's strengths, that we can really increase programs anyway, whether we're able to do all of the lofty things that we want to do here. I also have the idea of having a swing bed in the hospital. That way we can call it a hospice bed. And we've provided the services, but we've never designated the service for that, even though we've talked about it. And I think that would make it a lot more accessible for people with a terminal illness or a family that wasn't able to care for their relative at home, and to do that at home. So those are just some of the ideas that I have.
You had also mentioned, when you were talking to me, it was how do we bring the end-of-life nursing education training here?
Oh, yeah.
And seriously, we are trained, and we just don't provide it because we've never been asked. And it's an 8-hour training. I was asked, is it online? Well, there are parts of it that you could potentially do online. And like I said, CNAs or CHRs could attend just pieces of it. They don't have to be at all of it. But there are components of it that truly should be face-to-face, especially when you're doing the communication component, because that's the biggest hurdle for most of us, is how do I talk to somebody when they've been receiving bad news, or how do I deliver the bad news or the hard news, and then how do I help them in their decision-making once they've received that How do I help them and get them to those right services? So that's something that I am open to discussing and seeing what we could do, and numbers as to how we could provide that. So I'm curious about public health nursing. I understand public health nursing, but I also understand, thank you, Ruth, that for many of us, public health nursing is not home health nursing, because by regulations you are tied to what you can and you cannot provide. Can you enlighten us, and then is there a way that we can hub at all?
No, we're health promotion, disease prevention primarily. We're the opposite end of the spectrum. Everybody wants us to be home health because we go to the home, but we're totally opposite. We try to keep people from getting sick, and that's our goal, is immunizations. Our 5 priorities of care. First one is natural disaster, which thankfully we don't have much of. Communicable disease like tuberculosis and Shigella and all these things that are still out there just waiting, biding their time. And we have other types of communicable disease, STIs, that we have to follow up on. So we only have 4 RNs that are out in the field full time and 1 tech. So to cover 28,000 members. So you could see where even though we all want this, it's not always. And the third one is maternal child health, OB, like seeing prenatals. When I first got into public health, we had 9 nurses. Now we have 4. And we used to see our prenatals 5 times before they delivered. Now we're lucky if we see them once. We used to try to make 2 postpartum visits. Now we're lucky if we see them once. So we have, and then after maternal child health, then everything else, and that's where elders and all that. And Jess and I have been going out as a team and trying to visit elders more than anybody has in the past, because we're both, I'm not new to public health, but I'm new coming back. So we've kind of teamed up and have tried to focus more on the elders, but we have all our other work in addition to that. So we do it as much as we can, but it's, just like everything, you need more. We're asked to do more with less. So that's kind of our priorities of care. That's kind of a quick overview of the program, but it's health promotion, disease prevention oriented.
So if you think about palliative care as being started when a chronic illness has been diagnosed, so cancer, or if the chronic renal disease is kind of before it becomes end stage or whatever, there is a concept that palliative care is called health promotion palliative care. So if it was viewed as palliative care, and I'm not talking hospice care, I'm talking palliative care, is that something then that could be, but again, we're also talking staffing, which I understand that.
Yeah. You would have to talk to somebody at a higher pay grade than me. I'm not promising nothing.
Right.
Okay.
So right now, we're in a planning phase for self-governance. And self-governance is a law. It's a public law, 93-638, and that's under that law, we currently operate 3 programs, CHRs, ambulance program, and the alcohol programs. Well, there's 2 tracks under the law. Title I, which is the 3 I just mentioned, and there's Title V. And Title V is compacting. And when a tribe compacts, they assume complete responsibility of whatever service, function, program, or activity they're compacting. And so right now we are planning for the future if the Rosebud Sioux tribe chooses to utilize this law and compact healthcare, what that would look like and what that would take to make that happen. So my answer to the question you asked is, if the tribe does this, and we do compact public health nursing, for an example, then the tribe has the autonomy to say, these are our priorities. This is what we're going to reallocate this funding for, and these are the programs we're going to support with this funding. IHS does not have that autonomy to do that. They're strict guidelines and regulations that they have to follow, but once that responsibility is given over to the tribe under Title V, the tribe has the ability to make our own priorities and deliver healthcare in a manner which we feel is best meeting the needs of our people. And so Title I, we still have to follow that red tape, those rules and regulations within the health service. But compacting complete self-governance, that is, as the health director for the tribe, the vision I would like to share with everyone is to assume responsibility of this and establish what we feel is meets a healthcare delivery system that best meets our own needs. And so while health promotion and disease prevention is very important, how does that rank in priority compared to all of these other unmet needs that we have? And so it's just like the ability to do that. So to the extent that we can identify what needs that we have, what needs are already being met, and then we can develop steps on how to meet those other needs. But then we would have the ability to utilize this funding that's appropriated annually by Congress as startup funding or basic funding to support the development of more programs that are going to be reimbursable services. So they're like home health services is a reimbursable service if you have the professional staff delivering that care. So in theory, you would be able to bill and collect and eventually sustain that program through third-party revenue generation. So it's just about really having those startup funds to get these programs going and building sustainable programs that can be reimbursed for over time. So that's kind of like the direction. And then in the next 6 months, we'll have a plan to present to council that says if we choose to do this, this is the best way we would do this, and then just start going at it. But that's my answer to your question, and like how we can attack both and not be so tied down to what the federal government regulates.
One of the concerns I have as an elder is that you really don't have to have degrees to pass on this information. Basically, and the administrator, the health, what was her name at IHS? When she got one of these, she said, "We should have done this a long time ago."
It's a social worker.
Yeah. So wouldn't it be the social worker at IHS to pass this on if they're visiting our elders or our inpatient care? That's it. You don't need to go through a lot of bureaucracy or certifications to pass on that care. That education for our people. That's it.
Yeah, that's exactly what I was thinking too, Mrs. Catches. I think my idea is if we can get training for everybody that is in a professional capacity, public health nursing, the CHRs, some RNs from the hospital, some LPNs to go to the palliative care training course, then the more people that know what palliative care is, it's just going to disseminate it into the community, and then the families know what to ask for, and they know what's available to their elders to make their lives better. So if it's just a matter of educating everybody, and something like a pamphlet like this, like she said, you don't have to have a degree. We just need to re-educate the community, because I feel like the health care institutions have kind of done a disservice by providing so much extraordinary care and keeping people alive, even though they're terribly uncomfortable, and it's not a very compassionate healthcare delivery system. That's happened for years and years, and that's what people want, and they end up on breathing machines, and they end up with all kinds of surgeries that might not be curative. So I think that there's an enlightenment happening in healthcare where it's going to be easier to integrate palliative care and traditional medicine and cultural belief systems that are more appropriate to the community that you're serving. And my hope would be for that to continue to happen as we all work as a team, so everybody puts their strength into it, wherever it's coming from.
Do the individuals from the White River Clinic want to talk? About what you're thinking, or?
I believe we've got a lot of resources if we pull together.
Got to be really close.
To pull together, because there are a lot of people out there that need care, and I talk to them on the phone, see them in person, and they beg me, they look at me, and they don't want to go into the nursing home. They don't want to go out of their home. They want to stay there. And once we got socialized medicine here, I think some of their choices have got to leave. I was very impressed that we got invited to alternative medicines, cultural medicines next Wednesday. Are we going to use that in our palliative care? Are we going to offer those services to the people? Or is it going to be regulated again by the government? You know, this is what we want to do. I hesitated the other day. Can this person have a tea? Yeah, why can't they have this tea? This is the tea, their herb, and to help them, and it brought comfort to them. Yes, we wouldn't ask anybody else if they could have green tea off the shelf. So, and if that's what they want, and this is their home now, once you put them into the nursing home, that becomes their home to them. So let's offer that. If that's the palliative care we're going to give them, then let's give them all the choices if we're going to do that. And I think we do. We've got a strong team. She said tribes in trouble at the IHS, and I know financially it all comes down to money, but when does it come down? Let's take care of the people. And she's like, there's 28,000 tribal members out in healthcare. And then where is it? Where do we say, is it the family's decision, or is it the individual's decision to make that choice? How far are we going to go? Are we going to use the ventilator? Are we going to do the tube feedings? Or is it okay, I don't want to do dialysis anymore. It's okay, I just want to go to sleep. But then we're honest with them and the family to say, if you stop your dialysis, your kidney function's failing, you're probably just going to go to sleep. Is that okay with you? Or end-stage cirrhosis or our diabetes, because usually the diabetes has caused all these secondary complications. And our doctors on board with us, and the family. And we've got family members that aren't always on board. You might have 2, but you might have 4 others, and it puts us in a hard position because we want that person to be comfortable with their choice. And sometimes they're having a hard time making that decision because they want everybody to be happy with their choice. And they don't want to leave either, but they know what's ahead of them. I just think we need to all pray or ask somebody to help guide us all so we can work together to meet everybody's needs. And I hope this gets up and going and we start listening to what the people want.
And you raise a good question about palliative care, and there is actual documented evidence that palliative care, not talking hospice care, palliative care is cost effective because, again, we keep people out of the hospital, and you're integrating it early, so you're managing symptoms better. And also then when you initiate hospice care also is cost savings because we're spending thousands of dollars in those last 30 days of life. And a lot of it is due to unnecessary hospitalizations. But when about patient wishes and integrating traditional medicine and healing, that is essentially that definition of palliative care. It's what the patient wants. And we certainly go with the direction of what the patient wants as long as if they're of sound mind, obviously, and then safety, especially in the home. Are they safe at home? And then that's where sometimes you have to make that unfortunate decision if you don't have safety at home. Does anybody else have anything they'd like to share?
Now I'm speaking as a tribal member and not as a government bureaucrat, okay? My question is, why do prisoners get paid per capita more for health care than our people? Those type of things really anger me, because if we got paid, or even vets, they've got more money, why don't we get, the question was asked years ago about even service unit to service unit. One service unit got more than we did with same size population, all that, and it's like, how do these decisions get made? If we could have had that same amount of money that the other service, we would have been in the black. Things like that are, like I said, way over my, that to me, if we're gonna make significant change, those types of things, equal funding, I think our people deserve more funding, or at least as much funding as the prisoner does.
As you know, as tribal members in Pine Ridge, I know from listening to the council meetings and then watching them struggle with the basic finances. The tribe just contracted the emergency services in Pine Ridge. Now, I don't know how that's going to be, but, our people there, and I can name 2 instances that because of emergency, almost on a daily basis, our helicopter leave that pad at IHS on a daily basis. And you can imagine the cost of that. The cost of that flight, if not to Rapid, to Scottsbluff or to Sioux Falls. Sometimes even to Denver for burn. So it depends on the situation, but and I know that politics is always in there, and a lot of back and forth stuff, but when you're dealing with IHS, we're dealing with, I myself, if I go there just to get a refill, I can call it in if I want to, but if I'm going to see my primary doctor, I spend a whole day there. And by the time I leave the IHS, I am sick and tired of that place. And so, what is the best for our people doesn't always happen, realistically. And I know that the doctors and the nurses that do their jobs work, diligently and patiently and are overworked, sometimes are burnt out. But, we don't have a solution. All I'm about is to pass on this information so that somebody, sometime down the line, an elder can make a choice pertaining to her own health care. That's dignity. That's respect. And so, and I don't know everything, and I don't have a solution to everything. I don't profess to, but, it all boils down to is human care. How can we go beyond the box, beyond our allotted job description to lend a hand, to give information here or there? That's, it doesn't have to have a rocket scientist to know you know, talking from one heart to another is what we want, you know. When we had the Oglala Lakota College put an honorary for the elders, and I believe there was over 500 elders, and they had the traditional foods, and they gave each elder a little plaque, and I forgot what mine said, but then $100. Well, $100 goes a long ways too for an elder on fixed income. I'm retired now, so that's what we did. I mean, OLC did. But I think most of all the elders were there. There's just as much unaccounted for that didn't get there. So there is a big population of elders on both the reservations, probably everywhere, that aren't reached. And we did our best, Larry and I, and the other, but we're just a little group, and so we just try to do the best we can.
Just to speak a little bit, I guess, to what Deanne had mentioned about us having a much lower rate, as far as per person getting for healthcare. It could kind of go back to establishing the pipeline of professionals that we can produce, because this discussion has come up before, and we have recently got approval from Tribal Council. Half of our building is a big conference room at RST Tribal Health. So we're planning to turn that into a big computer lab where students are able to come in and start exploring different health professionals, practicing taking NCLEX, practicing taking SATs. So that's kind of in the works too, along with some of the stuff that Denise does with SJU and the job readiness fairs that they host. And then another big part of that too is SJU is looking to expand their biology program to a bachelorette. So that will open the door for more health professionals too. And then research is included in that also.
Good afternoon. My name is Vernon. I go by Ike Schmidt. I started working for the tribe. I don't want to give you my creation story because it could go on forever, but I started with the tribe after 3 years of college. I came back, and the gentleman that was running the HEW program, his name was Robert Sonny Wan. And before I left for college, I worked for him in a NYC program. So I got to know him, and he got to know me. So when I came back, I asked Sonny if he had any openings, and he put me in finance. At that time, the tribe 638'd a lot of the BIA and IHS programs, and so we had all of the probably about 14 programs. We had the CHR program, we had Johnson O'Malley, we had WIC, we had ambulance, alcohol treatment, just a whole gamut of the programs. And so that was during Bob Burnett's administration. As a matter of fact, Lois here was the treasurer of the tribe back then. So it was my first experience with departmentalization, and it was working good because of the coordination of the programs. Each one complemented each other, and they were able to provide more of a comprehensive approach to dealing with services in general out in the communities. 20 communities. And after about a year in finance, I wanted to get out into the community. So I was given the director of the CHR program. And that was quite the experience for me, because that gave me the opportunity to go out into the communities and visit people in their homes and really experience what their needs are. And back then we had a lot of families that didn't have running water, didn't have electricity. Their homes were in pretty ill repair. I think Darlene over here can go back to those days, because she's been a CHR for many years, so she's very familiar with what's going on out in the communities and in the people's homes. And we were able to put together a training program with the CHRs that was pretty comprehensive, kind of similar to what they do up in Alaska. They train their CHRs to be darn near physician assistant type level of training, so that because of the isolation up there and because of the remoteness, you know, some of the CHRs up there in Alaska are kind of some of the only providers until you can get to a medical facility. But to make a long story short, from those days, we've had some tremendous experiences with putting together community clinics. We had one going in Antelope, we had one going in St. Francis, and we had a mobile clinic going. And we had different clinics that we offered for the prenatal, the elderly, you know, infants, toddlers, you name it. We had a lot of good clinics going, and we were able to, through a memorandum of agreement, see that those patients were followed into the hospital. And we had a good working relationship with the hospital back then, where they took in all of the lab work. They took in, we was able to, with the medical records, we were able to coordinate that type of activity. And it's really, for that long ago, coming out of the 80s, you know, from the 70s into the 80s, and then when some of those services dried up, then some of the outreach services kind of dried up as well. But with the elder care, it all depends on priority from the top down. And there's been some different administrations as well as leaders in the Indian Health Service and what have you that were strong advocates for the elderlies. And our elderlies ourselves had a real strong advocacy group, Elder Concerns Group. And they went out and they did things, and they had things going on, and they really pushed for their particular needs. And I see a need for that to be regenerated in the last 10 years or so. It seems like some of those areas have just kind of slacked off, and we see a lot of the other tribes advancing with the direct funding and self-governance. I visited tribes in the Northwest, in Alaska, Oklahoma, out in Minnesota, and a lot of these self-governance tribes are doing tremendous things because they're in control. They're in control of the policy and procedures and funding, but the Indian Health Service still has an obligation to coordinate these services along with the self-governance tribes. I know in Alaska, the Indian Health Service has a strong presence up there with the health corporations. that are going there. And so they're still mandated to do the services that they're to be providing, but the ultimate decision-making is with the tribal entities. And up there they have a consortium, and they have a tremendous hospital in Anchorage. And so these are just some of the things I wanted to share, and I would like to see us here back at Rosebud get back into more of a strong advocacy for our elderly. You know, I'm at that age now where I'm pretty much advocating for myself as well, because I'm 63 years old, and I'm into that category now. So I certainly would like to help be a stronger advocate for providing whatever services that we could do. I know there are ways that we could generate more income once we get the certification for Medicare, Medicaid. There's a lot of, with the right trained staff and following the proper federal guidelines and procedures, there's a lot of third-party billing that could take place that could generate additional revenues. Pharmaceutical services, I think, was another area that we could. So there's a lot of ways to fund activities, and so I just wanted to express that in this meeting today, and I thank you for coming here and appreciate the opportunity. Thank you.
See, I don't think I have anything else. Does anybody? I think we've covered a lot of ground today and raised, I think, increased awareness and have maybe some tangible pieces that we can actually start to make progress. I think just even that brochure of raising awareness that these programs are available, and if it's about access, how do we make sure that that access or availability of those resources is actually there so that those services that are available can then be used. And I think raising our awareness that that's available has been tremendous. So thank you for sharing your information. And then seeing about how can we bring the training here to help enhance that level. So as Ruth said, so that everybody has that foundational knowledge so that we can at least raise the awareness about decision-making, choices, respect, dignity, and putting that final decision in the hands where it belongs, not with me, but with those individuals who it is their lives and what they choose to do. So thank you for inviting us to be here. We have greatly appreciated your hospitality, and it was just nice not just to drive through on 18, but actually stop once in Mission. So thank you so much.
I think we're going to be wrapping up here. I have to go jump on a call. I apologize. I have to leave kind of abruptly, but we had some gifts that we wanted to give our relatives that came to share with us today, and just thank them for making the trip and for sharing and for thinking of us. It really means a lot, and I think that this has started some good dialogue and good groundwork that we can build upon. One thing I would ask from each of the programs, if you haven't already done so, Denise, I think everybody should have Denise's email address, but what we're trying to do is put together a resource book and really put one together specific for elders and what resources are available for elders and how they tap into those resources. So if you could email Denise with what resources your programs have with regard to elders and kind of little, 1 through 4 steps, how they access those, that'd be great. And then we're gonna try to put that together and get those out into the communities as well. But if you want to... Do you want to announce about that resource fair that they're having on Friday? Here? Yeah, it's here. I don't know about it. I'll let Denise, I'll defer to... There's a resource fair on Friday. I don't know the details. Well, 10 to 3 here at SGU. Okay. Okay, so it's an elder resource fair here at SGU on Friday. Bingo. Everybody here, bingo will be here. Lisa's giving massages. I'll turn the mic over to you.
I would like to express my thank you to all of you. It's always touching and I guess, heartfelt. Thank you for having us and inviting us and feeding us, and for your kindness and courtesy for inviting us. Thank you. Wopila.
I would like to say thank you too. This has really been heartfelt. I got up, I know I've been sleeping here. I got up at 3 o'clock this morning. I was so excited to come, and I said I was an hour too early, so I said I was ready to head this way at 6:30, but we didn't start till 7:30. But it's really been a good experience, and this is really a good program that, if you do take it, well, it's going to be a good program, and we're always there. Our numbers are on there. You can call us anytime for any kind of help. And thank you.
I already said thank you. Does anybody else have anything? If not, you guys have a great day. Thank you for coming, and safe trip home.